Thank you for asking me to give a talk on statins and inflammatory myopathies. The idiopathic inflammatory myopathies are a heterogeneous group of autoimmune syndromes characterized by chronic muscle weakness and striated muscle inflammation, and the precise cause of these conditions is not known currently. There are four main subsets of disease: polymyositis, dermatomyositis, inclusion body myositis, and a more recently recognized entity of necrotizing myopathy. Necrotizing myopathy is histologically defined by findings of predominant muscle fiber necrosis with a paucity of inflammatory infiltrates. It is associated with both malignancy and active viral infections. Within necrotizing myopathy, there is a subset of disease called necrotizing autoimmune myopathy or immune-mediated necrotizing myopathy, in which immunological mechanisms are considered important in disease pathogenesis. And there have been two antibodies that have been recognized to be associated with NAM, namely antibodies to signal recognition particle, SRP, or antibodies to HMG-CoA reductase, the pharmacological target of statins. Statins have long been associated with a range of skeletal muscle pathology, ranging from myalgia to a self-limited statin myopathy which responds to statin withdrawal. Moreover, they're recognized triggers of idiopathic inflammatory myopathies, and more recently there have been found to be a subset called NAM, in which the myopathy persists or progresses despite statin cessation, implying that immunological mechanisms are involved, and this subset of NAM has been linked with antibodies to HMG-CoA reductase. Statins, there are a number of plausible mechanisms by which statins can have adverse effects on muscle function. The precise mechanisms are unclear, but some plausible mechanisms have been that reduction in cholesterol synthesis can lead to instability in cell membrane behavior. We know that there is a reduction in synthesis of intermediates in the pathway, especially mevalonate and coenzyme Q10. We also know that statins shift from a T helper 1 to a T helper 2 profile, and this implies a greater activity of B cells and a more production of autoantibodies. Statins have also been linked with altered skeletal muscle metabolism and a reduction in mitochondrial volume. We know that they interact with a number of drugs, particularly those metabolized by the cytochrome P450 system, and also they've been shown to have some pro-inflammatory effects by inducing TNF-induced apoptosis in endothelial cells. There are a number of genetic risk factors identified in statin myopathies. One of the important ones is the OAT-P1B1. This is a polypeptide which regulates the hepatic uptake of statins. The gene encoding this, the SLCO1B1 gene, is on chromosome 12, and GWAS studies have shown that common variants or SNPs in this gene have been strongly associated with risk for statin-induced myopathies. There was a study looking at a cross-sectional analysis of 136 patients with drug-induced myopathies, and in the control group were 116 patients on treatment without symptoms, 100 asymptomatic individuals who had never received treatment with statins, and 106 patients with non-statin myopathies. 110 of these underwent mutation testing, and it was found that 10% of cases were heterozygous or homozygous for three metabolic problems: CPT2 deficiency, McArdle's disease, and myoadenylate deaminase deficiency. Another study which looked at cultured muscle cells from patients with statin myopathies found that over half of these biopsies had abnormalities in mitochondrial or fatty acid metabolism. So there has been the question raised whether statin therapy actually unmasks underlying undiagnosed metabolic defects. There are a number of medications, as I mentioned, that interact with statins, and some of them are listed on this slide here: fibrates, cyclosporin, verapamil are some of the more commonly used ones, macrolide antibiotics, and importantly grapefruit juice also. Are all statins equal? Well, we know that it is a class effect, but no, not all statins are equal in their risk. The risk for pravastatin and fluvastatin is less than lovastatin, simvastatin, and atorvastatin. Prava and fluvastatin have more hydrophilic properties and are less metabolized by cytochrome P3A4. So there is a differential risk between the statins. So we know now I'd like to talk a little bit about the statin-induced NAM, or immune-mediated necrotizing myopathy. When you treat patients with statins, their cells increase their expression of HMG-CoA reductase, the enzyme. And we also know that regenerating muscle fibers express this enzyme. So when you withdraw the statin, there can be a sustained immune response to this pharmacological target of the statin even after stopping treatment. So statin exposure can lead to development of antibodies to the intracellular catalytic domain of HMG-CoA reductase, and this has been found in all patients with the antibody have been found to develop a necrotizing myopathy. So what do we know about HMG-CR antibodies? What has already been reported in the literature? In a large cohort of 750 patients with suspected inflammatory myopathies, they were detected in 6% of patients, but they were rarely detected amongst patients who were on statins who had self-limited musculoskeletal symptoms such as non-specific myalgia. We know that testing for antibodies to HMG-CR by ELISA has a high sensitivity and a high specificity. We also know that these antibody levels correlate with CK levels and with the degree of proximal muscle weakness. There have been reports that have suggested that antibodies can persist despite clinical improvement following immunosuppressive therapy, and the close parallel between titer of antibody and CK levels and proximal weakness, and the close correlation of these antibodies with statin-induced NAM has suggested that testing for these antibodies is useful in patients with suspected statin NAM. In the last several years, we've established a database of patients with biopsy-proven inflammatory myopathies in South Australia. We've gone back and collected all the biopsy-proven positive cases subsequent to 1980. This has been largely possible because of central reporting of all adult muscle biopsies in our state. The laboratory uses stringent and well-validated histological criteria for diagnosing PM, DM, IBM, and NAM. We use routine immunostaining for MHC class 1 and 2. In the database, we've recorded demographic, clinical, and laboratory details of these patients and stored DNA and serum on a large proportion. More recently, we've done a study looking at anti-HMG-CR antibodies in our South Australian myositis cohort. This was done in collaboration with Pathwest Perth, and we looked at the correlations of these antibodies measured by ELISA with clinical, serological, and immunogenetic markers. So we had 207 sera that we tested for these antibodies, and we found that 19 of these patients were tested positive for antibodies to HMG-CR. So the frequency in our IIM population was 9%. Interestingly, it was not detected in any of a reference control group, so they were quite specific to this subset of disease. Then we looked to see whether the distribution, whether these antibodies occurred preferentially in patients with NAM. And actually, you can see from this slide in the middle column, patients who are antibody positive, and you can see that these are roughly equally distributed across the different subsets of inflammatory myopathies. So there was no real difference, and they did not preferentially occur in patients with NAM. They occurred they were seen in all subsets of disease. We then looked at the odds ratio for positivity with different risk factors. So among patients who were antibody positive, the odds risk that they had used statins was 39. So 31% of patients who had inflammatory myopathies who had antibodies to HMG-CR had prior statin use, whereas only 0.1% had not used statins. So the odds risk for statin use was 39 amongst patients who are HMG-CR positive in patients with inflammatory myopathies. Looking at another genetic marker, a class 2 allele, DR11, the odds ratio for this was very strongly positive at 50. And then if you combine the two, patients who were typed positive for DR11 and had statin exposure had a very high odds ratio of 80 for developing these antibodies. So this is considered a very, very, very strong correlation. We then had a look to see if there was any difference in any of the other clinical features, the prevalence of other autoantibodies, connective tissue diseases, cardiovascular risk factors, and the only thing we found was possibly a signal for higher occurrence in patients who had diabetes. But this was no longer significant after adjusting for gender and statin use. So there were no clinical associations with other clinical features for these antibodies that we could determine. So we found overall a relatively low prevalence of these antibodies, so around 9% in an overall cohort of patients with inflammatory myopathies, including those with NAM. And we found that the antibodies were strongly associated with statin use, DR11, and they were weakly associated with male gender. We found an extremely high positive predictive value of 90% for developing anti-HMGCR in DR11 positive patients who had been exposed to statins. And this raises the possibility of raises a question of whether we should be typing patients for HLA prior to prescribing statins. But at present, it's a little premature to recommend this, as we don't really know what proportion of patients with these antibodies will go on and develop myositis. We've done another study looking at the clinico-serological features in our Royal Adelaide Hospital cohort of patients with statin NAM. So we retrospectively identified patients with statin NAM at the Royal Adelaide Hospital in this 4-year period. We included patients who had had current or previous statin exposure, patients with a clinical myopathy with a raised CK and possibly with a supportive MRI, and the histopathology was in keeping with a necrotizing myopathy. We excluded patients who had not had prior statin exposure, who had active malignancies, where muscle biopsies supported an alternative diagnosis, and we did not include patients who had self-limited statin myopathies. We identified 16 patients, 7 male, 10 female. Average age of diagnosis was 65. I've shown some of the other features here. The mean CK was over 6,000. The initial MMTH score assessing muscle power was 65, and at latest follow-up was 76. And what we were quite impressed by, or what was quite striking, was that 9 of 16 patients had quite prominent documented truncal weakness. We then looked at whether amongst this cohort of statin NAM, we compared those who had HMGCR antibodies, the 8 of them, with the 6 that did not. So you'll recall we had 16 patients and HMGCR antibodies had been tested in 14 because this study recruited patients before testing for this antibody became available. And we found that HMGCR antibodies were very strongly associated with truncal weakness. So 7 of the 8 patients who had HMGCR antibodies had prominent truncal weakness, whereas only 1 who was antibody negative did. And interestingly, there was no difference in the peak CK levels or the mean MMTH score. So the HMGCR antibodies selectively seem to target the truncal musculature, and this was not explained by a more severe myopathy, as there was no real difference in the peak CK levels or the overall MMTH score. Just out of interest, we measured serial titers in 8 patients. 2 patients, the antibodies subsequently became negative. 1 patient had a reducing titer. Another patient became negative in his antibody, but then relapsed together with clinical relapse of the disease. So we were interested to note that these antibodies seem to be associated with truncal weakness in patients with statin NAM. We found that these antibodies can disappear with treatment, paralleled by clinical improvement, and it does seem, as previously reported, that persistence of these antibodies may confer a poorer prognosis. The other question that we asked over the last few years was, are patients with histologically confirmed inflammatory myopathies more likely to have been exposed to statins? So we undertook a retrospective population-based case control study between 1990 and 2014, wherein we recorded all patients with biopsy-proven cases from the South Australian myositis database, adults aged over 40. So we compared data on exposure to statins with controls, which were matched 3-to-1 on age and gender from the Northwestern Adelaide Health Study. We used conditional logistic regression analysis to calculate crude and adjusted odds ratios, adjusted for cardiovascular disease and diabetes. We identified 221 cases and 662 controls were used. You can see the statin exposure documented in red here. So 68 of the 221 cases, so 30.8%, had been exposed to statins, whereas only 21% of the controls had been exposed to statins. And there was no difference in diabetes or osteoporosis or other cardiovascular risks. When we adjusted for cardiovascular risk, diabetes, etc., the adjusted odds ratio for statin exposure in inflammatory myositis was 1.79. And when we looked at inflammatory myopathies excluding the subset of NAM, the adjusted odds ratio was 1.92. So in summary, over the last several years have seen significant progress in understanding statin myopathies and delineating the entity of statin NAM. The identification of anti-HMGCR represents a significant advance in this field, and this has both diagnostic and prognostic value. Further work really should focus on genetic risk factors and identifying who is at risk. We need to clarify the role of DR typing in risk assessment. We would be interested in undertaking longitudinal analysis of anti-HMGCR titers, and we need to also work out what is the optimal treatment of statin NAM, as data on this is still forthcoming. In conclusion, I'd like to acknowledge everyone who has helped to support the South Australian myositis database, my colleague rheumatologists, neurologists and general physicians, and all the patients who have contributed, and the Department of Anatomical Pathology. Dr. Mike Waters did the study on statin NAM serological features. Dr. Gillian Cohey from the Department of Pharmacy was involved in the case control study. And the antibodies to HMGCR study has been done in collaboration with Drs. Chris Bundell and Drs. Hollingworth from Perth. So thank you.